So, renal disorders, chapter 22. Like I said, this is fairly complex kidney stuff. I'll try to break it down to make it a little bit easier. The PowerPoints are just the pre-canned PowerPoints from the book. Big thing to know about the kidneys is they do all kinds of stuff. Kidneys do tons of stuff. Big thing, acid-base balance, and also blood pressure regulation. They're also responsible for red blood cell formation. The kidney disease, rates of kidney disease are growing in the United States. And I really think a big part of that is actually because we're paying better attention to kidney health. So if you go do clinicals at any of the 3 hospitals in town, you will have acute kidney injury, AKI, as a diagnosis on probably all of your patients. It's easily one of the #1 comorbidities. And a big thing that feeds into acute kidney injury and also end stage, there's more of the chronic version of it, is diabetes. Diabetes. So the skyrocketing cases of diabetes are fueling the skyrocketing cases of kidney problems. And here in a minute, I'll explain why that is. I'll draw a little picture on the board, I think. The kidneys receive about 1/5 of the cardiac output, and we measure the GFR, which is the amount of blood filtered per unit of time, and that's directly related to renal perfusion. So renal perfusion, that's the key here, is how much blood is pumping into the kidneys, specifically through the renal arteries. How much blood is pumping through those kidneys, and we call that the GFR, and it tends to go down with aging. The nephron itself is the basic functional unit of the kidney. It processes filtered fluid. The end product is urine. So your kidneys are just cleaning out your blood and making pee, making urine. The nephron overview is super confusing and something I remember we had to memorize way back in anatomy and physiology class. I would encourage you to kind of look at this picture just for an understanding of the nephron. But do nurses really need to know the proximal tubule, the loop of Henle, the distal tubule? Not really. I can't think of a single time at the bedside where knowing this has helped me take care of the patient. But there is a lab test that you will want to know, and that's called the creatinine. The creatinine is a very specific number, a lab test. We draw your blood and check your lab work, and you get your creatinine value. That value is very, very specific to how many nephrons have been damaged. How many nephrons have been damaged? So if your creatinine is normally 1.0, does anybody know what their most recent creatinine was? I think mine was. Yeah, so like normal is 0.5 to 1.2, somewhere in there, depending on which, where you got your labs drawn. But the thing to know about creatinine is if it goes up by 1/10 of a point, just 1/10 of a point. So if you're normally 1.2, your creatinine, if you go up to 1.3, you've lost something like 40% of your nephrons. It's a highly specific lab test that tells us your kidneys are taking a hit. So whenever you look at a patient's creatinine, be thinking about this slide here, this picture of these nephrons, because if it goes up 1/10 of a point, these nephrons are dying. They're taking a hit. I'm going to skip a bunch of slides to this slide that's a big picture of the kidney. Remember, we're talking about the creatinine, which is a measure of your kidney function. If it elevates, you've got potentially 3 different causes. So as the nurse, our job is to start thinking about the 3 potential reasons that creatinine elevated. We don't worry about too low of a creatinine. That's just not even a thing. I had a student put that on her concept map this week and tried to figure out, what does it mean if the creatinine is too low? Too low, not a thing. It's just not even it's just a normal variant. If it's too low. Too high is always a problem. If you bump up 0.1, 1/10 of a percentage, you now have a diagnosis called acute kidney injury, AKI. And it has one of these 3 causes, either pre-renal, intra-renal, or post-renal. One of these 3 causes, by far the #1 cause, is pre-renal. Pre-renal, #1 cause, over 80% of the time. If somebody's kidneys are shutting down, they have a pre-renal cause. Pre-renal, all it means is your blood pressure tanked. Your blood pressure tanked. And the number that we are specifically interested in, as far as blood pressure, how low is too low, is your mean arterial pressure, your MAP. How low is too low? Less than 70. If your MAP is less than 70, your blood pressure is too low, you are not getting adequate perfusion to this kidney, and nephrons will start dying. When enough nephrons die, your creatinine starts going up. Normally, your kidneys are filtering out the creatinine. When it elevates, it means you have kidney injury. Most of the time, pre-renal. We got to be looking at pre-renal causes, which is usually septic shock. That's very common. You drop your blood pressure because you have sepsis. That's very, very common. Anything that causes you to drop your blood pressure is going to hit your kidneys. Pre-renal. Intrarenal is the second most common cause. And so if you think about, we have a septic patient comes to the ER. We know this person is septic because they have a fever. Maybe their temperature is 101. Have a fever, and then have a source of infection. Maybe they've got a diabetic foot ulcer. Maybe they've got a rotten tooth. A decent number of people get a rotten tooth, and it causes bacteria to enter their bloodstream. They get septic. So you have this patient who's septic, and their blood pressure gets too low. Bam, kidneys take a hit. And then, how do we treat sepsis? We start IV antibiotics. The intrarenal, which is damage inside the kidney to the actual structures, is always caused by something we gave them. The most common cause, actually, is IV contrast dye. So if we send this person over for a CAT scan, because we don't know where their infection is, their blood pressure is low, we got to find that infection. Where's that infection? Let's give them a CAT scan. When we do the CAT scan, if we infuse the dye, what we call radio contrast dye, that's the leading cause of intrarenal kidney damage, contrast dye. Other very common causes are other antibiotics that we give, like gentamicin, vancomycin. Some of those meds are very hard on the kidneys. Lots of different chemotherapy meds, very hard on the kidney. So your creatinine is raising, it's going up. First, we got to look at that blood pressure. Is it okay? Is the mean arterial pressure greater than 70? Number two, we got to look at what meds are we giving that are very hard on the kidney. What meds? Most of our computer systems now do this automatically. So the EPIC, EHR, electronic health record, EPIC, which all the hospitals use now, automatically does this. And it will say, it will give you a big red flag when you log into your patient's chart, big red warning. It'll say, hey, your creatinine bumped up 0.2 of a point, and we noticed your patient is on this med. So EPIC actually is really nice because it will scan the whole list of meds. As soon as that creatinine bumps up, start figuring out what med caused it. The third cause of your creatinine raising, which means your kidneys have taken a hit, is what's called post-renal. And this is when you can't pee for some reason. You can't pee. You can't pee, and urine starts backing up. Urine starts backing up. It will back up all the way into the kidney and cause that kidney to swell up. That kidney can swell up so much it can almost burst. The fancy word for that is hydronephrosis. It basically means your urine is backing up and it's causing that kidney to swell. But what would cause an obstruction to urine flow? A kidney stone, that was one of the answers here. Definitely a kidney stone can cause post-renal obstruction. Anything else that you guys can think of that could cause post-renal obstruction?
Kidney stones.
Kidney stones, yeah. Probably the most common cause of this in real life. Kidney stones can do this, but here's a little secret about kidney stones. They very rarely cause your creatinine to go up. They can cause what's called a hydronephrosis, and you could even lose that kidney. Urine backs up and causes the kidney to swell. But your creatinine stays normal. Why is that? Because you only need one kidney. And usually if you have a kidney stone, it's only on one side. So a kidney stone can cause post-renal obstruction, but we might not even notice. Because when we draw your blood and check your creatinine, it's still fine. So the obstructions that we worry about the most is the obstructions that can cause both kidneys to swell up. And the most common cause is a bad prostate in men. Yep, called BPH, benign prostatic hypertrophy. So for you men in the group, we get to look forward to this at about the age of 65, because 100% of men age 65 and older have BPH, which means at some point that prostate is going to completely clamp off urine flow. And then that urine backs up and can cause serious kidney damage. That's called post-renal, most common cause, BPH, bad prostate. It's really not a bad prostate. The word benign means it's actually just normal, something that happens as men get older. So if you're a little old man in the state of Nebraska, let's say you are a farmer, 75 years old, and your prostate is obstructing urine outflow, what are you gonna do? Because that would hurt like the dickens. You know how it hurts when you have to pee really bad in class and you don't want to get up in the middle of class and leave? You feel like you need to pee when your bladder has about 300 milliliters in it. That's kind of the rule of thumb. Bladder has about 300 mLs. You feel, oh, I gotta go pee. You get up to about 1,000 mLs, that's a liter. Your bladder can hold that, but you will be in excruciating pain. Hurts like the dickens. You get up higher than 1,000, and now that urine is backing up your ureters and causing your kidneys to swell. So what's a little old Nebraska farmer to do? Because it's embarrassing. One thing, they're gonna try to fix the problem themselves. And they come into the ER with knitting needles stuck, or all kinds of different things that they'll try to, because it makes sense, just basic plumbing. You got a plugged drain, you're gonna go after it. So we do see that a lot. The preferred thing is a Roto-Rooter, we call it, which is where the urologist goes in and just kind of expands that out. But anyway, that's post-renal. Very rare that, by rare, I mean like maybe 10% of the kidney problems are post-renal that caused it. Most common, pre-renal. You get too dehydrated, your blood pressure tanks. You get sepsis, your blood pressure tanks. All the different reasons for your blood pressure to drop can cause pre-renal kidney failure. And then all the different meds that we give in the hospital can cause intra-renal, which means they just directly insult those kidneys. Any questions about those three? Pre-renal, intra-renal, post-renal? And the lab test we're looking for is that creatinine. We also look at the GFR as well, but the creatinine is a great lab because it's very specific to the kidneys. So the next few slides do talk about pre-renal and then intrarenal. One thing that could cause intrarenal dysfunction other than meds is an infection of the kidneys. So we do have to be looking at kidney infections. That's called a pyelonephritis. You have a urinary tract infection and the bacteria moves up to your kidneys, and now you've got a pyelonephritis. And so that is a problem we want to get right on top of. The problem with pyelo is if you've got an infection in that kidney, that's a very vascular organ because all of your blood flows through that kidney. So a pyelo can cause bacteria in your bloodstream, which means you are now septic. Sepsis is the leading cause of pre-renal, but the pyelo itself is causing damage. So you can just have a 1-2 hit if you have a kidney infection. Then there's different autoimmune conditions like lupus. And then here's a list of some of the meds that are notorious for causing kidney problems. Your NSAIDs, so your ibuprofen. Ibuprofen can be hard on kidneys. ACE inhibitors, hard on kidneys. But the most common nephrotoxic drug is actually IV contrast dye that you get when you have a CAT scan. Notorious for shutting down the kidneys. To take a look at the rest of these slides, I want to explain real quick why diabetes is so hard on your kidney. And if you have a patient with end-stage renal disease, ESRD, that's the patient that's on dialysis. They're almost always a diabetic patient and usually a poorly controlled diabetic. Poorly controlled. One thing about your type 1 diabetes as opposed to your type 2 diabetes. Type 1 diabetics are what we used to call juvenile onset. They're your kids, the kids that get diabetes. And type 1 is an autoimmune problem where your body has attacked your pancreas. That's type 1 diabetes. And we used to see a lot of kidney failure patients who had type 1 diabetes, but one of the exciting things about the Apple Watch and a lot of the other fitness tracker, they have kind of pushed the technology to where we're trying to get all those type 1 kids an insulin pump and a patch that measures their blood sugar 24/7. The patches are great because they just sync to your phone. And if you're a child, it also syncs to your parents' phone. And so if you're in the 3rd grade and you're out on the playground and your blood sugar gets low, it calls your parents, it might notify your teacher. And if it gets low enough, the Apple Watch is exciting because it has fall detection. And so unresponsive, the Apple Watch knows that now because it has what's called an accelerometer built into it. And so what we see now is the Apple Watch is calling 911, and it just gives a 911 dispatcher the lowdown. Got 3rd grader at such and such school, been unresponsive for 3 minutes, blood sugar is currently 22. And so the paramedics know exactly what they're getting into, show up on scene. It's actually, I think, an exciting time. The technology has really improved the outcomes. And it's improved it so much, actually, that Medicare, Medicaid won't usually pay for an ambulance ride to the hospital now because the paramedic standard of care now is paramedics bop in an IV, give an amp of D50, and then they don't even need to transport. They just stay on scene until that person is eating. If they're eating a nice solid meal, we know their blood sugar can stay up. Anyway, so that's the exciting thing. Type 1 diabetes used to be a death sentence, and it meant, man, you're going to be on dialysis by the time you're 30, end-stage renal disease. But now not so much. What we are seeing now all the time is our type 2 diabetes. And how do you get type 2 diabetes? You just eat too much sugar for too long. I'm vastly oversimplifying that. But really, the standard American diet has led to pandemic level type 2 diabetes. So here's the problem with insulin. I'm going to draw on those whiteboards. So let's just draw a body cell. This is a body cell. I'm getting a glare from that window, aren't I? Here's a cell in your body. To stay alive, this cell needs something. It needs nutrition. And the nutrition that all of your body cells need, it gets it from your bloodstream. Let's draw a blood vessel along here. There's a blood vessel. My little cell here. And then here's a blood vessel. So the number one nutrient that your body cells use is glucose or sugar. And if you think to yourself, I'm on an Atkins diet. I only eat high protein. Well, protein is broken down into amino acids, and amino acids are then broken down into glucose, essentially. At the cellular level, the mitochondria need sugar. As it turns out, you can use a secondary fuel source called fatty acids, and that's the basis of the ketogenic diet. But anything else other than fat that you eat, complex carbohydrates, protein, are broken down essentially at the end to glucose to fuel those mitochondria. The problem with the standard American diet is we eat way too much sugar. Way too much sugar. We eat so much sugar that if all of that sugar was to dump into this cell, those cells would start dying. And what do cells need to uptake sugar? Very important receptor. And that's your insulin receptor, and then the chemical insulin. So insulin allows glucose into our cells. But as our cells become insulin resistant, then they stop allowing glucose in, which it needs to do to stay alive. And if you're wondering how old do you have to be for this to become a problem, like what's the average age of a type 2 diabetes diagnosis? The average age of a new diagnosis of type 2 diabetes, which is adult onset, that's what we used to call it, age 13. That's kind of average now. Because by the time you're 13 years of age, you've eaten so incredibly much sugar that your insulin receptors have shut down. Here's a problem, though. A big problem. That much sugar is very toxic to cells. These muscle cells are doing fine because we've shut down those insulin receptors. There's at least 3 or 4 cells in your body that do not need insulin for the uptake of sugar. And some of those cells are brain cells. I'll write the different types of cells here. Neurons. Neurons don't need insulin for the uptake of sugar. Red blood cells. They don't need insulin for the uptake of sugar. Neither do white blood cells, as it turns out. Nephrons. So we've been talking about kidney stuff, specifically your tubular cells in your kidneys do not need insulin receptors for the uptake of sugar. Your retinas, as it turns out, your eyeball cells do not need insulin receptors for the uptake of sugar. So what that means is all of the devastating side effects of diabetes could be tracked to what type of cells don't need insulin. Neuropathy, all of our diabetics can't feel their feet any longer because their nerve cells are shot. And it's very common to have a diabetic come into the ER after he stepped on something. I had a guy not that long ago. He came to the ER. What was his chief complaint? He smelled bad. I don't know, but something smells like rotting flesh. I don't know what it is. It was the bottom of his foot. He had stepped on a toothpick like 2 weeks before probably, and his foot was rotting away. Gas gangrene. And the toothpick was still sticking out of his foot. He'd been walking around on it for 2 weeks. Couldn't feel his foot. He was obese enough, he couldn't look at the bottom of his foot. He just knew something smelled bad. That's neuropathy, which is caused by high blood sugars, and those sugars just suck up into those nerve cells and cause all kinds of damage. That's also why some people who have a heart attack don't have chest pain. Diabetic patients are notorious for having a rip-roaring heart attack, and they never present with chest pain. They show up because they just don't feel right. Something doesn't feel right. It's because the pain receptors in their heart muscle, those neurons, are shot. They don't even feel pain, which is a nice problem to have, but then you don't know when you're having a heart attack. Red blood cells. The problem with red blood cells, let's see if I can draw this somewhere where there's not a glare. I'm going to draw just one more picture, then we'll take a break. Here is a capillary. Can you see that okay? Here's a capillary. Here is a red blood cell. This red blood cell has to go through that little tiny capillary. What do you notice about the scale? I drew this to scale. That red blood cell is way bigger than that little tiny blood vessel, right? So how in the world does that red blood cell get through there? Let's pretend that this capillary is in your big toe. And to keep your big toe alive, you have to get your red blood cells through this little capillary to feed your big toe. How do you suppose that red blood cell does that? It can change its shape. It can change its shape, and the fancy word for that is deformability. It just squeezes its way on through that capillary. The problem is when you consistently run a blood sugar of like 400, that red blood cell becomes crystallized and it can no longer fold or bend. It loses its deformability. What happens if that red blood cell can't get down that capillary to that big toe? The circulation cuts off and that toe starts to die. This exact same thing happens in the kidneys. These red blood cells start plugging up because they can't squeeze through. It happens in the kidneys, and a leading cause of end-stage renal disease is diabetes. What about your retina? The back of your eyeball. There's little tiny capillaries on the back of your eyeball on your retina. They get all plugged up. It's called, technically it's called diabetic retinopathy, the leading cause of blindness. Your diabetics go blind. Their kidney shut down, they go blind, they lose their big toe, it gets amputated, then they lose the rest of their foot, and then they lose their entire leg. First we do a below the knee amputation, and then we do an above the knee amputation. Then they lose the other toe on the other side, and pretty soon they are a bilateral amputee who's blind and on dialysis.